Hi guys, welcome to Radiology 365, where we try to cover core radiology from cover to cover. Today we're going to be talking about the mediastinum, and we are starting off with anatomy of the mediastinum. Now there are several methods that have been proposed to divide the mediastinum. This discussion is going to follow the International Thymic Malignancy Interest Group 8MEG method that has been accepted as a new standard. So the mediastinum is divided into 3 arbitrary compartments to aid in the differential diagnosis of a mediastinal mass. However, there are really no anatomic planes separating those divisions, and disease can spread from one compartment to another. The 3 divisions are the prevascular compartment, the visceral compartment, and the paravertebral compartment. So we're going to use these 3 images to get to understand the anatomy of the 3 different compartments of the mediastinum. Starting off with the prevascular compartment, that's the blue color-coded compartment in these axial and sagittal CT scans. The prevascular compartment is bordered superiorly by the thoracic inlet, inferiorly by the diaphragm, anteriorly by the posterior border or the posterior cortex of the sternum, and laterally by the parietal mediastinal pleura, and posteriorly here by the anterior aspect of the pericardium. Essentially, it contains the thymus in children or the thymic remnant in adults. There are also lymph nodes and blood vessels that run through that area. Next, we'll talk about the visceral compartment. That's the pink or red color-coded area here. The visceral compartment is bounded superiorly also by the thoracic inlet, inferiorly by the diaphragm, anteriorly by the posterior boundaries of the prevascular compartment, that's the anterior border of the pericardium, and posteriorly by a vertical line that connects the thoracic vertebral bodies 1 centimeter posterior to its anterior margin. So if you look at the anterior margin of the vertebral bodies, draw or assume 1 centimeter posterior to the anterior borders, and then that gives you the posterior margin of the middle mediastinum. Essentially, it contains the heart, the great vessels, the trachea, and the esophagus, and also most of the lymph nodes, the mediastinal lymph nodes, are in this compartment. The phrenic, vagus, and recurrent laryngeal nerves also pass through this compartment, and they are around the aortopulmonary window within this compartment. And the next one is the paravertebral compartment. That's the yellow compartment here. The anterior boundary of the paravertebral compartment is basically what was the posterior boundary of the middle mediastinal compartment or the visceral compartment, and that's 1 centimeter behind the anterior margin of the vertebral bodies. Then the posterior boundary is a vertical line along the posterior margin of the chest wall at the lateral aspect of the transverse processes. So if we come to the axials, you realize that considering this to be a transverse process, the lateral margin of the transverse process marks the end of the mediastinum. The mediastinum doesn't go all the way to the back here, right? Next, we'll talk about lines, stripes, and interfaces in the mediastinum on a typical frontal radiograph. Now, interfaces between anatomic structures in the lungs, mediastinum, and the pleura may be displaced or thickened in the presence of a mediastinal mass or an abnormality. When we mention a line is basically a thin interface that's formed by tissue typically less than 1 millimeter in thickness with air on both sides. So the posterior junctional line, for instance, would be a line because it's a very thin line with air which is in both lungs on both sides of this line. We'll get to know a little more about it later. A stripe is a thicker interface that is formed between air and adjacent soft tissue. Then an interface, the word interface is when we talk about the contact of 2 soft tissue structures of different densities. So because of their different densities, when they are put side by side, where they meet, we would see a line, and that line would be called an interface. So those are the terminologies. While I'm giving this descriptions, kindly keep an eye on the illustration that has been shown here. to know the exact places that would be ideal for you to look for these particular lines and interfaces. The anterior junction line is formed by 4 layers of pleura. That's the parietal and visceral pleura of each lung. And it's called junction because it's basically where both lungs meet. And once they meet at a point, the parietal and visceral pleura of both lungs are meeting at that same point, creating this line. We have a line anteriorly like that, and we have a line posteriorly like that, the posterior junction line. So we can see the classic location of the posterior junction line on that we would see on the radiograph, and the anterior junction line, this red line here, that we would also see. They can be sometimes very faint, and it's very dependent on the quality of the images taken. Some of these lines and interfaces that we're going to be talking about. When you have abnormal convexity or displacement of the anterior junction line, it suggests a prevascular mediastinal mass. And when you have abnormal convexity or displacement of the posterior junction line, it may suggest a paravertebral mediastinal mass or aortic aneurysm or something like that. Then we'll talk about the right and left paratracheal stripes. These green lines here, the right paratracheal stripe and then the left paratracheal stripe. These are formed by 2 layers of pleura. That's the parietal and visceral on one side, where the medial aspect of each lung abuts the lateral wall of the trachea and the intervening mediastinal fat at that area. The right paratracheal stripe is the most commonly seen of these 2 landmarks, and it's seen in up to 97% of normal posterior anterior chest radiographs. When you have abnormal thickening of the right paratracheal stripe, it's most commonly due to a paratracheal mass, including adenopathy or thyroid or tracheal neoplasm. Thickening of the left paratracheal stripe also has similar differentials. A mediastinal hematoma should also be considered in the setting of trauma. The posterior tracheal stripe or tracheoesophageal stripe is only seen on a lateral radiograph, not on a frontal radiograph. And that represents the interface of the posterior wall of the trachea with the 2 pleural layers of the medial right lung. Then we have the right and left paraspinal lines, these orange lines here. They are actually interfaces. And remember we mentioned that interfaces are formed at the point where 2 soft tissue structures meet, right? So they are actually interfaces, but they appear as lines due to the Mach effect. The Mach effect is like an optical illusion where certain lines become more prominent on radiographs. So the right and left paraspinal lines are formed by 2 layers of pleura abutting the posterior chest wall. That's what gives us the paraspinal lines. In contrast to the posterior junction lines, the paraspinal lines are located inferiorly in the thorax. So you find them here, while we are seeing the anterior and posterior junction lines more superiorly. The posterior junction line seen higher up compared above the clavicle compared to the anterior junction line. The paraspinal lines are rather more inferiorly seen, typically from the 8th through the 12th ribs. A paraspinal line abnormality would suggest paravertebral mediastinal mass, including a hematoma, maybe a neurogenic tumor, some aortic aneurysm, extramedullary hematopoiesis, an esophageal mass, maybe an osteophyte. Then we have the azygosophageal recess. That's an interface formed by the contact of the posteromedial right lower lobe and the retrocardiac mediastinum. The azygosophageal recess extends from the subcarinal region to the diaphragm. If we follow the trachea here, bifurcating here, so this is the trachea, looking just below the carina all the way down to the diaphragm, we should see the azygosophageal recess there, again also dependent on the quality of the radiograph you are looking at. When you have distortion of the azygosophageal recess, it may be due to an esophageal mass, hiatal hernia, left atrial enlargement, and adenopathy as well. The aortopulmonary window is a mediastinal space nestled underneath the aortic arch and the top of the pulmonary artery. The medial border of the aortopulmonary window is formed by the esophagus, the trachea, and the left mainstem bronchus. On a normal frontal radiograph like this one, we would see the AP window has a shallow concave contour below the aortic knob. So this is the aortic knob, and then we have this concave contour here representing the aortopulmonary window. When you have an abnormal convexity, that's an outward bulging of the aortopulmonary window, it suggests a mass arising from or involving structures that normally live within the aortopulmonary window. The retrosternal clear space is a normal area of lucency posterior to the sternum, and it's seen on the lateral radiograph. It correlates with the prevascular space on a CT scan. Obliteration of the retrosternal clear space suggests a prevascular mediastinal mass. It could also indicate right ventricular dilation or pulmonary artery enlargement. When you rather have this retrosternal clear space increasing, it could suggest emphysema. So in this lateral radiograph, we see the normal retrosternal clear space as this area of lucency just behind the sternum. And like we said, when this clear space is not seen, it could be a mass filling that space or right ventricular enlargement. You know, the right ventricle is an anterior chamber, and so if it were enlarged, it would also fill this space, amongst others. Finally, we would mention the left superior intercostal vein. It's not often seen on normal radiographs, but when it's visible, the left superior intercostal vein produces an aortic nipple that's appearing as a small round shadow to the left of the aortic knob on the frontal radiograph. The left superior intercostal vein may be dilated as a collateral pathway when you have superior vena cava obstruction. So in this 3D reconstructed CT angiogram of the great vessels, we see this vein wrapping around the aortic knob, and on a plain radiograph you may see this nipple-like projection as a bump on the aortic knob, which would call the aortic nipple. It's a normal variant, and it's not something you should worry about when you see. Like I said, it could suggest a superior vena cava obstruction. Thank you very much for your attention. I hope you found some value from this brief anatomic recap. The next thing we'll talk about is the radiographic localization of a mediastinal mass. If you're finding value from these videos, give it a like, give it a thumbs up, leave a comment, share with someone you think would also appreciate this, and I'll see you in the next one.